Hello, welcome to video 3 of our 3-part video series answering frequently asked questions regarding pediatric respiratory tract infections. My name is Kristin Schmidt. I'm an infectious diseases and antimicrobial stewardship pharmacist in Regina, and I'm joined by Dr. Rupesh Chawla, who is a pediatric infectious diseases and antimicrobial stewardship physician in Saskatoon. The objective of this video series is to answer frequently asked questions regarding assessment and treatment of common pediatric respiratory tract infections encountered in primary care, with the aim of ensuring that antimicrobials are used as appropriately as possible. This video will cover lower respiratory tract infections in children. So to begin with, I'll pass things over to Dr. Chawla to give us a bit of a background before we start with the questions.
Thank you so much, Kristin. So as Kristin said, we're going to be talking about lower respiratory tract infections in children today. Before, however, we start, just as a reminder again, we would strongly recommend you all to have the First Line app on your phones. If you take care of children, we find it's going to be very helpful for you in regards to some guidelines, some pathogen and antimicrobial information for people who are prescribing and taking care of kids. So if you download that, it's for free on the Apple Store as well as the Google Play Store. The important part is once you download it, it's important when you're looking for the guidelines to make sure that you're on the Mum and Kids or Jim Pattison Children's Hospital site so you get the appropriate pediatric information. There are other parts from Saskatchewan that will give you more adult information, but we want to make sure that you're getting the pediatric information. So we're going to be talking about lower respiratory tract infections today. And in children, they consist of basically 3 entities. One is bronchiolitis. Second is a pneumonia, which can be through a variety of etiologies. And third is a pneumonitis, which can be related to often viral and also a variety of irritants. So the large majority of lower respiratory tract infections in children are definitely related to viral agents and a large reason for overprescribing of antibiotics in pediatric patients.
Yeah, so let's answer some questions to help us know when antibiotics are needed and when they aren't. So number 1, what is the best method to determine if a lower respiratory tract infection is viral or bacterial?
Great question, Kristin. I think that's the biggest problem for practicing clinicians, is that there isn't a great test that tells you a patient is bacterial or viral and makes the diagnosis sometimes very difficult to make. So there's no gold standard test. There's no, people have touted things like inflammatory markers or CBCs and things like that. There's nothing specific, but probably again, like a lot of things we've talked about, history is a very important part of when you make a diagnosis of a bacterial versus a viral infection. Often they give a history of having a viral illness and then a secondary worsening or an abrupt worsening with the higher grade fevers, or the patient becomes more lethargic, more unwell. And that's when you get that secondary bacterial process. Other things are abrupt rigors also favor a bacterial process. In pediatrics, pneumonia can be a very non-specific type illness, and they have very non-specific symptoms in younger children. So if you have acute onset fever, cough, shortness of breath, poor feeding, vomiting, lethargy, it's important that you're looking for what's important in regards to what to investigate for. But that doesn't mean that's a bacterial illness, but it means that there probably is a pneumonia going on. In kids, the physical examination is also a bit more difficult. They often don't have all those classic signs that we see in adults. So if you're seeing a child with fever, tachypnea, and increased work of breathing, that is a good reason to do a chest x-ray. We're going to talk about that in the next slide. I've left a little slide there in regards to it's important for different age groups that different respiratory rates are what's discussed as tachypnea. So in regards to what is the normal respiratory rate for different age groups is listed there, and what are the upper limits are in regards to when you're actually breathing too quickly. So on top of the clinical presentation, my strong recommendation is that if you're suspecting a pneumonia, you should do a chest x-ray. Okay? If you have a classic story of a child who's wheezing or presenting during upper respiratory season lower respiratory tract season in the wintertime with typical bronchiolitis type symptoms and have this chest that sounds like bronchiolitis, which basically sounds like wheezing mixed with popcorn sounds in your chest, you're going to not do a chest x-ray. But if you're considering a pneumonia in your differential diagnosis, you should do that. And the reason for that is twofold. One is it could help you with your diagnostic ability of whether it's a bacterial, viral, or atypical process. And also, more importantly, if it's completely normal, it's not pneumonia. Maybe think about another diagnosis and avoid antibiotic therapy in that situation. Okay. So with chest x-rays as listed there, if you have more alveolar or airspace disease or what's called consolidation, you may see air bronchograms, which are quite adult. That would fit more of a bacterial process. Viral, you often see poorly defined patches, infiltrates, or atelectasis. And then with atypical pathogens like mycoplasma or chlamydia, they often have bilateral or focal interstitial infiltrates extensive relative to milder per persistent symptoms. One other thing I really do want to bring up here, especially in light of the fact that we're seeing lower rates of immunization history becomes very important in this situation because we're certainly seeing other cases of things like pertussis in patients with lower respiratory tract infections. So if you see clinical symptoms that are suggestive, and especially if the patient's immunization history show they're not protected, pertussis itself can give you a lower respiratory tract infection and a pneumonia type picture, and testing can be done specifically for pertussis.
All right, are there any other investigations on top of the imaging you've already talked about which can help to determine the etiology, or is this the gold standard?
So realistically, in most outpatient management of pneumonia, which should be the majority of patients that you're going to see with pneumonia, the chest x-ray and your clinical history and physical examination are the majority of things you would do. We do not recommend doing any blood work like CBC, blood cultures, or inflammatory markers in typical patients. NP swabs looking for viral etiologies again shouldn't be done in outpatient management. But if their patient is admitted, all those tests may be considered in that scenario. But realistically, in outpatient management, chest x-ray and a history and physical examination is where you should stop.
Great. So moving on to treatment then, what would be the antimicrobial of choice for bacterial pneumonia, and what would be the recommended duration of therapy when we're treating somebody out in community?
So I think, again, the big point here is that most community-acquired pneumonia, as I said, is viral, but if you're deciding that this is a bacterial process, the majority of those patients can be managed as outpatients. So that means oral therapy. A lot of them do not need to be admitted to hospital or need parenteral antibiotic therapy. So the reasons that you would consider parenteral therapy is if there's basically inadequate PO intake, they're just vomiting and intolerant of PO intake, they have a severe illness or respiratory distress, or worry of a complicated pneumonia, and sometimes in younger kids as well. At less than 6 months of age, you should strongly recommend those sort of patients should be admitted to hospital and consider parenteral antibiotic therapy. In regards to the agent, therapy should be directed against the most common etiology. So if you have a bacterial etiology like we talked about that's consolidative in nature or infiltrative in nature, really therapy should be concentrated against strep pneumonia. Strep pneumonia, in regards to therapy, like we have talked before in our previous videos, you need to consider whether there's risk factors for resistance for strep pneumonia or not. Risk factors for strep pneumonia include, number 1, having been on antibiotics in the previous 3 months, number 2, daycare attendance, and 3, less so, young age. So if they're less than 2 years of age, those can also be resistance factors. If there are no resistance factors present, the treatment is amoxicillin as an outpatient at a standard dose, 40 to 50 milligrams per kilogram per day, divided 3 times a day. If, however, those resistance factors are present, you do want to use the high-dose amoxicillin at between 80 to 100 milligrams per kilogram per day. In this situation, we do recommend for pneumonia dividing it 3 times a day, unlike for the other disease processes like otitis and sinusitis we had talked about BID dosing. But for pneumonia, we do want you to use 3 times a day dosing for pneumonia for the amoxicillin at high dose. If they do get admitted to hospital, which we can talk a little bit about, but basically ampicillin should be the choice. And if they're more unwell, then ceftriaxone and then higher grade therapy. The other situation for outpatient management that should be, we're going to talk about, is those that have those chest x-rays that are not the typical consolidative pattern, but more that bilateral bat wing type appearance and infiltrative sort of pattern, which is more suggestive of an atypical organism, which tends to be mycoplasma or chlamydophila causing your pneumonia. In that situation, generally azithromycin or clarithromycin at the doses suggested on the side in the chart are suggested for the 5 days for the azithromycin and 7 days for the clarithromycin. Back to in terms of treatment, if you're using the amoxicillin for the typical bacterial pneumonia, if you have one that does not need admission to hospital and you're just treating as an outpatient, the grand majority of patients of community-acquired pneumonia can be treated with a course of 5 days, up to a maximum of 7 days. They should see improvement within 48 hours. If they're not, they should be reassessed.
Great. So I'll just remind our viewers again that we have additional resources in the bundle. So we do have a handout on dosing of amoxicillin and amoxiclav also for these common indications. And Choosing Wisely and RX Files both have a viral prescription pad also that you can use for those patients who you diagnose as having a viral infection instead of giving a prescription for antibiotics. So thank you so much, Dr. Chawla, and thanks to our viewers also. Please check out the other videos in our series as well as the other resources included in the bundle. If you'd like to further this discussion, we invite you to attend a live webinar and a Q&A session with both myself and Dr. Chawla during World Antimicrobial Resistance Awareness Week on November 21st at 12 p.m. We hope to see you there.
Thank you very much, Kristin.